So you acknowledge the fact that you are aware that the brachial plexus is super complicated, right? Super complicated. And it's important for you to kind of, I'm not going to ask you this. I'm not going to ask you what branch, division, all that stuff, right? But remember I said real Texans drink cold beer? Yeah. So roots, trunks, divisions, etc. That's where that little mnemonic comes from to remember it, right? So if you do take it upon yourself to learn this and know it well, it'll make sense to you. Because as it branches down into these little divisions down here, then you start understanding how those things affect patients peripherally or distally, depending on how you look at it, okay? So if you have seen this before, if there's interest, I'll post it. Otherwise, I literally just stole this off the internet. So, but it's important to understand this because we talk about C5 through T1 as far as brachial plexopathy, right? And you see how this picture here, this illustration, goes from C5 to T1, right? So you understand if there's either compression or traction forces with brachial plexopathy or brachial plexus injuries, that you can have these divisions, for lack of a better term, probably not the best term, but these different extensions of the brachial plexus, depending on where that lesion is, it can manifest itself in different ways, and you can have different physical exam findings. Okay, so we're all on the same page about that? Okay, again, if you take it upon yourself to look at that a little bit more, good on you. It'll just help you understand it a little bit better. But I will not, again, just to be clear, I will not test you on the brachial plexus specifically and give you an example of a lesion in one specific spot, and you have to work your way down those real Texans drink cold beer and figure out what I'm talking about. All right? I'm not going to do that. Okay? I don't know what you're going to do in neurology, but I'm not going to do that. So, all right. Any questions about lectures yesterday? No? Okay. So we'll move on to impingement syndrome then. Okay? So again, like I spoke of yesterday, it's important to understand that when it comes to all these shoulder exams, very commonly, and this is not just PA students, but PAs in practice, physicians in practice, nurse practitioners, etc., they don't understand their shoulder exam, right? So they can't make sense of it. Hopefully I'll help you guys get to a point where at least you can make some sense of it and use your physical exam to guide your differential diagnosis, at least be in the right ballpark as juniors, and then be dead square center target as seniors, right? Because when you go to phase 2, and this is getting to a meeting I had over the last couple of days, when you get to phase 2, do you think the instructors out there, the preceptors, the phase 2 directors, do you think they're going to care when you say the statement, "I never learned that"? No. What happens then is that if you truly didn't learn it, not that you weren't taught it as you're eating popcorn during the lecture at 15:10 on a Wednesday, right? But if you truly didn't learn it, right, for whatever reason, you're going to quickly learn it, right? Because you're going to excuse yourself, right? Sir, ma'am, really got to use the restroom, is that okay? And you're going to run to the bathroom, and you're going to bring up Dr. Google, right? And you're going to look something up, and you're going to come back, and you're going to respond, right? Or the next day, and you're going to have that knowledge. That is your charge going forward, because do patients care that you didn't learn it in PA school? And I say that in air quotations. Patients don't care. Right? Does death care? Death doesn't care, right? That's what we're all fighting. Let's not kid ourselves. When it comes to certain patients, right, we're trying to extend their life, right? We're trying to battle this pathology, give them the right medications, give them the right therapy, give them the right treatments. That way, they don't meet an early grave, right? As much as possible. Unfortunately, we can't win every time. But having said that, so that's why it's important to, if you don't have that knowledge, at whatever point in your training, that you find a way to get that knowledge. So why am I rambling on about this? Because I have found since I've been here that maybe we don't do the best job of really telling you what resources you should be utilizing, okay? So to that end, I have compiled a list of references that I think could help you in phase 2 especially, okay? And I will give those to you, okay? I don't give this to you right in the beginning of my lectures because does some of that information conflict in some way, shape, or form, or maybe lead to confusing you, right? As I'm lecturing about this from this specific textbook, Yes, so I find that that may be a disservice to some. Because although you are thirsty for knowledge, right, I don't want to give you too much too fast, okay? You good, sir? Yeah, good. He's full. He's right. So, popcorn stones. I love those ones. All right, so does that make sense? So if I forget to give it to you in whatever way, shape, or form, or timely fashion that you would like it in, let me know. But usually I give it to you towards the end of your blocks. Okay? So remind me. If you want other specific recommendations, I will give those to you as well. Good to go? Okay. All right, impingement syndrome. Enough about that. Impingement syndrome. So impingement syndrome is a diagnosis that's very commonly misused. Very commonly. Okay? And as we get into our lectures, I'll go ahead and get to it. Is it very common for the average young, otherwise healthy person, military member, let's say, to have a rotator cuff tear? No, it's not. Okay, according to the literature, it is not. Okay, and according to my clinical practice, it's not either. Rotator cuff tears are something that happens either due to trauma, right, or due to degenerative, right? So chronic rotator cuff tears, like we keep talking about. So I guess a better way to phrase that question would have been: do a lot of young people routinely sustain acute traumatic rotator cuff tears just from, let's say, working out? No, it's not common, okay? So I know you guys will disagree with me with that, but you're just going to have to trust me on the fact that when you talk about impingement syndrome and you use it in otherwise healthy young adults, then maybe that's not the true classification of impingement syndrome, regardless of your symptomology, okay? So I'll ask you that question again tomorrow after this lecture, and we'll see where we're at, okay? Because you can either fight me on it or you can go along, okay? So, impingement syndrome, by definition, what is it? So the supraspinatus tendon, as Lieutenant Bishop told us yesterday, that's above the spine of the scapula, right? God, now you got the terminology. High five to himself, right? So supraspinatus, right? So yes, that's true. But more importantly, it's also running underneath the acromion, correct? So it's the subacromial burst inflammation goes with that too. So that's the definition of impingement syndrome. So it can be very kind of catch-all for some patients, right? Because they may just have anterior shoulder pain, right? And you can't discern whether it's the bursa or whether it may have something to do with the rotator cuff tendon, which specifically in this case is which one? Supraspinatus, correct? And you remember when we were doing the lectures on and radiology, right, for MSK, we talked about specifically that one slide where I showed you the picture of the MRI with a coronal slice that showed this illustration, essentially, okay? And again, how you see this impingement that's being highlighted here, okay? This impingement is being highlighted here. That is what we're talking about here, okay? So, with the impingement happening, I thought you were asking a question, sorry. So, with the impingement happening, can it be due to an abnormally shaped acromion as well? Yes, and we'll talk about that today too. Okay, so there's a lot of factors involved there, right? So you notice how they talk about the coracoacromial arch, right? So that's that arch is created by all those structures we were just talking about. So it could be a multifactorial issue where you have that impingement. So a lot of times, to be quite honest with you, it is worthwhile getting an MRI because you can look at all that, right? But we don't get MRIs right away on all patients, correct? Especially if there's no history of trauma, or if it's something we can identify as chronic overuse, like maybe just working out too hard, right? Gym rats. Okay, we can let down on the workout a little bit. They improve, we move on. Okay. So what's the thing that's highlighted in yellow here or gold? Acromion, right? So that's the big thing that we want to understand here. Okay, because when we're doing our tests, right, our special tests, are we putting the acromion into compression to try to see if it reproduces your symptoms? Yes, right? So that's something we'll get back to, okay? Any questions about this illustration here? No? Okay. So gradual onset of anterior and lateral pain. So we already talked about why it could be lateral, right? Why it could rotate to the lateral region, because it's the deltoid, right? So activation of the deltoid can cause some symptoms as well. Okay, so it's not uncommon for someone with impingement syndrome to report that they also have lateral shoulder pain i.e. on or about the deltoid as well, okay? But will they have pain with cross-body activity? Yes, right? So again, is that putting compression on that coracoacromial arch? Yes, okay? Will they have pain when they extend their arm away from their body? Yes. Will they have pain when they extend their arm over their head? Yes. So why do I keep saying these things over and over? Because when you guys are talking to your patients in clinic and you're getting this history, this chronology of their symptoms, they're going to tell you things like that. So you got to take it beyond saying, okay, when you work out, it hurts. Where does it hurt, right? You got to ask them specifically which motions, which activities bother you the most. If they say it's cross body, so they're basically doing dumbbell workouts, right? Or they're saying they're doing overhead workouts with heavy dumbbells, and that's causing most of their pain, you're kind of zeroing in on that, okay? Because like I keep telling you guys, is pain going to tell you necessarily where the pathology is? No, right? Because what if they do have anterior and posterior shoulder pain? So then you're going to try to qualify that, okay? Or quantify that, I guess is better. You're going to say, okay, you say your shoulder hurts both in the anterior aspect, in the subacromial region, right? And also posteriorly, but what's the distribution there? If they tell you that it's 80% anterior subacromial region and 20% posterior scapular region, you're going to take that into account, right? Because then when you do your special test, you can try to nail it down just a little bit better. Does that make sense? So I tell you guys that because if you get to phase 2 and one of your preceptors asks you, well, you say their shoulder hurts and they say it just hurts everywhere. Okay, fine. But Lieutenant Bishop, and I'm not picking on you, your name's just easy. All right, Lieutenant Bishop, tell me about this pain. Do they have more pain with these activities or more pain with that activity? Okay? And you're going to try to nail it down and say, well, I think they have impingement syndrome, but I think they might also have blank, right? Because we haven't talked about pathologies yet, so we'll get there. Okay? Good to go? So that's just something to keep in mind, okay? So when it comes to impingement syndrome, right, again, most of the people, when they have that impingement of the subacromial arch or the coracoacromial arch, 60 to 120 degrees is about where they're going to start experiencing that pain, okay? And that's what that little picture is demonstrating there. Where are they going to have the most of their pain, though? Usually it's horizon and above, right? So at about 90 degrees to about 120 degrees. And in orthopedics, or just in medicine, we call that a painful arc, okay? So you would document it as patient has full range of motion, but a painful arc when going from 90 to 120 degrees. See how specific you get there? Okay? I'm trying to nail it down. Okay? If they have an impingement and they lay on that side, and is that going to cause more impingement? Yes. So that's literally what they're going to tell you. They're going to say. You're going to ask them, right? Because you guys are going to remember this stuff for sure, 100%, right? Yeah? Don't laugh back there. Yeah, you're going to remember it, right? You're going to ask them, do you have pain at night? And do you have pain with sleeping on that side? And you're going to say yes. Because what are the 3 things that drive people to want to do something? Work, play, and sleep, right? That's one of them, right? And the play is the overhead activity, working out at the gym. Okay? Makes sense? And the work is they can't lift a rifle overhead. Why would you want to do that, right? That's punishment. But I'm just saying they can't do whatever it is they need to do in the performance of their daily activities. Okay? So superior and posterior muscle atrophy, well, that can be present due to a number of reasons. But if they have long-standing impingement syndrome, do you think they're going to want to do certain things? No, right? So they can get atrophy just from disuse. Everybody understands what I mean by disuse, right? You don't use it, you lose it, okay? Oh, and by the way, if there's impingement in the brachial plexus, right, does the brachial plexus eventually innervate all the musculature of the shoulder? Yes, so they can have wasting, okay? Wasting due to neurologic impingement as well. So you remember how I told you, and I keep telling you, that when it comes to shoulder pain and neck pain and elbow pain and wrist pain and just generally upper extremity pain, you really got to nail it down, right? And again, if a patient tells you their neck hurts or their shoulder hurts, you got to ask them if the other one's hurt, whichever one they're not saying, right? You got to try to nail it down, try to figure out which one it is, that you believe is the most troublesome. And then you have advanced imaging that can help you with that, right? And what's that study you can get if you need to differentiate between certain types of neurologic compressions and or peripheral neuropathy? What was that? EMG neuroconduction study is what I heard. Okay, good. All right, that's what I heard. So, okay. Any questions about that so far? I just keep trying to put it all together for you guys. That's why I keep going over and over with this, right? Because you can't learn one thing and dump it and be like it has nothing to do with shoulder because it's neck, right? It's just not that easy, correct? Make sense? And it makes you look better as a provider because you understand that. Because if you send somebody to me that has some labral pathology of their shoulder, but they have significant neck issues, radiculopathy, are you think we're going to operate it on them before they get the radiculopathy addressed? No, right? The labral tear, let's say they'll pick one, right? The labral tear is not going to really affect them long term, per se, but the radiculopathy could, correct? Yeah, so they're going to address that first. So if you haven't addressed it as a primary care manager, as a family practice person or whatever, then you're missing the bigger picture. You're sending them to us, but we're sending them right back to you, right? And that's why. Okay, makes sense? Okay, we're not mean, I promise. Well, some of us are, but on physical exam, what are you going to feel? What are you going to experience? The patient's going to feel, right? They're going to, when you push on certain bony landmarks, and I've taught you all the bony landmarks you need to know, right? You guys all know how to find a greater tuberosity now, right? You know where it is. When the arm is straight up, so if you're standing at attention, the greater tuberosity should be lateral, correct? Yes. And the medial and the lesser tuberosity, or tubercle, should be medial, correct? And what runs between the greater and the lesser? The long head of the biceps tendon? Yes, you guys know this. You guys know this. And that's called the bicipital groove, right? So now you know how to document your findings on physical exam when you go to your OSCE and you say, hey, I'm going to palpate these bony and soft tissue landmarks. What does that mean? You're literally just going to do what you do on the OSCEs. You're just going to, as Colonel Sylvester would say, twinkle fingers, right? Magic fingers. You're just going to do a bunch of stuff and none of it means anything? No, you're going to try to put all these findings together. Makes sense? So, okay? So, getting back to that 90 to 120 degrees, like I said before, even though they can have pain from 60 to 120, most patients will experience significant pain, more significant pain, when going from 90 to 120. So basically, horizon and above, okay? We good with that? All right, so yeah, let's get back to it. I spent a lot of time with physical exam, right? A lot of time with special testing. Do you think, and I think you've already answered this question and you know the answer, do you think I'm going to ask you questions on the test that describe one of these tests? And you must understand not only how to do it properly because you know what I'm describing, but what a finding is, right? And more importantly, what a positive versus a negative finding is. And like you said, the answer is yes, okay? So getting to it again, Job test, we're going to go through all these tests in the lab, don't worry, okay? But the Job test, what's the number one purpose for a Job test? Is it looking for pain? I'll give you choices. Is it looking for pain, comma, weakness, comma, or pain and or weakness? Pain and or weakness, correct. Okay, so, and again, because when you're doing this test, you're testing for which tendon? Which component of the rotator cuff? Supraspinatus. So you see how I key into that, right? You need to know supraspinatus because it just shows its head, no pun intended, in a bunch of different places in all these different pathologies, okay? So again, you're looking for weakness more so. That's the number one reason, okay? So, and they're going to have weakness with the Job test. So what's the difference between, excuse me, we've already kind of talked about this, but the Job test, is it okay to, let's say, do an O'Brien's test, right? And then take them like this, put them just straight forward, so forward flexion, 90 degrees, and do it on this plane? Is this a Job test? No, you take the arms out and you have it in the plane of the scapula. That's what it's called, right? Because that's putting it to where the supraspinatus and infraspinatus, respectively, are both free, if you will, and you're able to test them without any kind of compression. Okay, that's the reason you do it in this position. Okay, that's kind of a layman's way of saying it, but that's why you do it. So this is a Jobe test, this is an O'Brien's test, right? This is a Speed's test. They're all done in different positions for a reason. Good to go? Were you guys taught that? You say yes. Okay, good. Near test. So the way I teach near test, near to the ear, right? So you put the arm / elbow, depending on, how long, if somebody has a gorilla factor going on, so it might not be near their ear, right, their elbow. But basically, is this a test that you do passive or active? Do you ask the patient to do it or you do it? You do it, right? So this is a passive test. Because again, I keep getting back to this principle that if you ask the patient to do it and it hurts, are they going to give you maximal effort? No. So don't be that person, okay? And again, do you have to do this crazy internal rotation? No. But you want to bring the arm close to their ear, right? And is that going to recreate some kind of impingement in that coracoacromial arch? Yes, as well. Okay, and that's what you're trying to reproduce, okay? So that's a near test, okay? Hawkins-Kennedy. Some people call it Hawkins, some people call it Kennedy. But you guys are probably taught, like in this picture, right? You're probably taught the arm just forward like this, right? So 90-90. Everybody sees what I mean by 90-90. And then just rotate in, okay? It's not the wrong way to do it. It's definitely a Hawkins-Kennedy. But more importantly, we also do it dynamically for a lot of patients because as we keep talking about, you guys already know this concept from yesterday, the more you internally rotate, do you cause more compression? So do you think the more you go across the body and basically turn a Hawkins-Kennedy into some kind of modified crossbody that they could have more impingement to? Yes, so that's the only thing I'm saying. For the purposes of IPAP, you just do it like the picture represents and like you guys were taught. That's not wrong. But again, somebody may experience more symptoms. I'd say it's kind of like on the fence, right? You're like, I don't know. They say they're having pain, but it's not significant. But now you go a little bit more cross body, and you're still doing that internal rotation, right? But now they're having more symptoms, then it's more of a positive finding. Does that make sense, or did I lose anybody? Okay, and we'll go through that in lab, don't worry. But we're going to demo, right? It looks like I'm going to be the one doing the demoing, so we'll just have one large group now, okay? So, but we'll talk about that a little bit more. So, any questions about these tests so far? I added this slide. I showed the pictures here. Jog the memory, if you will. If you have questions before we get to lab, great, ask them. But definitely ask questions when we're in the lab, okay? Because everything doesn't test for impingement, and everything doesn't test for labral pathology, correct? So you've got to be able to dissociate those things and understand if you do all these tests, what's positive, what's negative, and because of these combinations of what's positive and negative, this is my diagnosis. Make sense? Okay. If it doesn't, it will. I hope. Okay. So imaging-wise, we talked about already. Usually, we're going to get at least 2 views. If you can, you want to get an AP view and an axillary view, right? Those are the 2 views that you hopefully can get. But if you can't get an axillary view, okay, because of pain or what have you, then what's the other view we can get? The scapular Y, right? And the scapular Y is helpful in this. Would you agree that this is a scapular Y with everything else taken out? Yes, right? So this top structure here that has the line, right? That's, as you progress across here, you can see the curvature, right? When you get to type 3 there, that looks like a pretty extreme curvature, right? Pretty extreme angle there. Okay, so that looks like it's going to cause some compression, correct? So a scapular Y view can be very useful in deciding if the patient has what's called a down-sloping acromion. Okay, so type 1, normal, correct? Everybody sees that, straight line across? Okay, type 2, a little bit of a curve, right? Type 3, again, not really a curve, just a sharp turn, right? And then type 4 is like the unicorn, right? It's causing compression, but it's actually going the other direction. But because of the increased angulation, it's still causing significant compression, okay? So if you ever see why am I telling you this? If you see a radiology report and it says down-sloping acromion, right? And you did your exam, and you have positive Hawkins-Kennedy, positive crossbody, and a positive NIRS, Does that sound like impingement syndrome? It does, right? You see how you put your exam together with your imaging, right? Because you guys have heard the saying, I hope, by now, that you don't treat images, you treat patients, correct? Right? So for example, if you get an image report, right? I hope you're looking at the images, especially in phase 2. Don't worry, you will be. It's on my criteria for evaluation. But if you're not looking at your imaging, and you're getting all these crazy reports, what do you do with that information, right? How do you decide what to do with the patient? I always wondered that, but look at your imaging when you're in phase 2, okay? So if you have impingement syndrome, is that something that could cause significant deficits? No, we're not talking about neurologic stuff, right? But pain can cause significant limitations in activity, and if you have chronic pain, that could be bad, right? Don't give them narcotics, right? But why do you get rotator cuff tendonitis again? From impingement syndrome? Because it's impinging on the tendon, correct? Right? In this case, we'll focus on the supraspinatus, right? And over time, it's causing inflammation, right? And if you're causing inflammation, can you cause microdegeneration of the tendon? Yes, then that's where we start getting into that terminology you guys already know about partial tears, right? Right, so you get those micro tears at first, you really can't see those on MRI, but then over time you can get an MRI, say in 2 years, and now you see a progression of that tear, and it went from tendonitis to a gross tear, okay? And that's what that's saying right there. It goes from tendonitis to rotator cuff tear. Okay, good to go? All right, we're good with that? All right, good. So non-operative treatment, all the conservative stuff, all the regular stuff, okay? So stretching of the posterior capsule, so what does that mean, right? So has anybody here been to physical therapy for a rotator cuff tear? Rotator cuff tendonitis? Okay, what kind of? 20 years ago? Okay. I don't know if I can use that, but let's say it was 2 years ago, right? So when you went and saw Mr. Willick, right? He was the PA in the clinic, as I destroy furniture. And he was a PA in clinic, and he sent you to physical therapy, and he told him, he said, give him rotator cuff strengthening and scapular stabilization exercise program. That's what he asked physical therapy to give you, right? And you've been doing it, but you stopped doing it. Do you think that the impingement might come back? Do you think that the tendonitis might come back? Yes, right? So usually, again, if there's a cause, it's not like you just do the physical therapy for 6 weeks and you're good, right? You have to keep doing it, all right? Especially as we get older, I want to say more mature, right? And more seasoned, right? Things tend to get stiff, right? You tend to be less flexible. So especially in your older population, you really got to tell them to continue doing those exercise programs. Okay, but you should be telling it to everybody. So what did I say? Rotator cuff strengthening and scapular stabilization, right? So it's not only making sure that the rotator cuff is strong and supporting the head of the humerus in the glenoid cavity, but you got to make sure that the stabilizers of the scapular are just as strong, right? Because they provide that very important balance in the shoulder, okay? Is your shoulder capable of a wide range of motion? Yes, but it sacrifices it for stability in some positions that you put yourself in, okay? Make sense? So that's what you're going to do, okay? Is any of that testable? No. Move on down with those. All right, so you've done all that physical therapy. Now they come back to your clinic. If you're skilled and licensed, have the supplemental credentials, to do corticosteroid injections, might you do them? Yes. Okay. Now, as you guys probably know, they obviously have a therapeutic reason for doing them, right? There's a therapeutic reason for doing them, right? But did you know that there's also a diagnostic value in doing corticosteroid injections? No? Maybe? Okay. Yes. Well, then today I'm going to teach you that. So, because when you send them to me, right, and I kind of prefaced this already, this situation, when you send them to me and the patient says the same thing I said to you, 80% here, 20% there, If I inject in one specific region, say the subacromial space, and try to figure out if that's their main complaint, that's their main issue going on, and they get 100% relief of all their pain, is that my number one diagnosis? Yes, right? If I do an injection of the subacromial space for therapeutic reasons, right, they get pain relief, but they still have 20% pain at the AC joint, the acromioclavicular joint, do I still think they might have some AC joint pathology that needs to be addressed? Yes. You see how it's just gone from not only therapeutic, but to also diagnostic, right? So that's why I teach you this, right? I give you the cheat code now and tell you that when patients present with shoulder pain, right? Like when you presented with shoulder pain, you probably went in there and you said it hurts here, right? 20 years ago, right? You couldn't lift your arm? Okay. So, but could you point to one spot where it hurt the most? Not right now, I'm just saying then. Yeah. Now you do whatever you want. But I'm just saying, it's not, sometimes it's not as direct, right? So sometimes, and you'll learn this in ankle pathology too, in block 4, maybe for me now, right? And we'll talk about that later. But you may inject the ankle in one specific spot to see if it relieves all their pain. Because do we have something called referred pain? Yes, right? So if they don't have any referred pain after that, then you've nailed it down to where their main issue is, okay? But the same rules apply. How many injections are you going to do within a 12-month period? 3, right? How many injections do I do? Nobody tells me how many injections I can do. No, I'm joking. But the point is, if you're not, especially if you're not getting any relief from it, then you should take the diagnostic component of it and try to figure out what the patient needs, right? Good to go? But the rule is 3 within 12 months. Okay, does Ortho break that rule? Yes. But for IPAP, 3 in 12 months. Okay? Good to go. Non-operative treatment failure, that's when we want to see them. We want to see them when you've done everything you need to do, right? Because impingement syndrome, right, if we're talking about the subacromial space, is the subacromial space and the acromioclavicular joint, are they in the same place? What I mean by that is, can you get to the glenohumeral joint through the acromioclavicular joint? No. Okay? You cannot. You don't go from the top to get to the front, right? So what I mean by that is you really got to nail it down and figure out what it is you're addressing. Okay? And obviously imaging helps too. Okay, so that's when we want to see them after you've sent them for all the appropriate conservative care. Maybe you've done an injection, maybe we've done an injection. Because what are we going to do? If there's compression in the coracoacromial space, or the arch, excuse me, that's the subacromial space, what's the surgery called? Subacromial decompression. Okay? So you can do that arthroscopically, but you cannot address the top side of the acromioclavicular joint from the same approach. Makes sense? So you got to figure out what you're talking about. If you don't remember any of that, just remember subacromial decompression. Okay? All right? There you go. You're welcome. Okay. All right. So risks, I mean, obviously, be careful with your NSAIDs, right? If you're going to talk about injections, don't do any greater than 3. Is the supraspinatus muscle a tendon? Yes. So if you do them either incorrectly or too many, could you risk rupture of the supraspinatus tendon? Yes. Okay. So don't miss that. Okay. Rotator cuff weakness. Anytime you have weakness, and this is getting back to what I was saying earlier, sir, is that when you have your injury, right? Everybody calls me and says that the patient has weakness, right? They don't want to do anything, and I'm like, do they have weakness? Like true weakness is a deficit, correct? They are unable to perform that action, either due to a nerve issue or due to a continuity of the musculotendinous unit, correct? So, for example, the supraspinatus tendon is torn, therefore they can't elevate their arm. Okay, abduct their arm, I should say. Okay? So, no, if he presents just with pain, right, just from working out especially, then maybe he just has weakness, perceived weakness, just because he doesn't want to do it because it hurts. Do we understand the difference? Right? So when you call me and say the patient cannot elevate his arm, what do I hear again? Challenge accepted. Correct. So no matter how much pain the patient has, my job is to go figure out, do they have true weakness? Because depending on the stuff I'm going to talk to you about when it comes to rotator cuff tears here in a second, is we need to do something about it, right? And what is that something about it? Surgery, right? Do the Lord's work, okay? So again, important to understand that the difference between those two, okay? All right, keep going. Keep going? Okay, rotator cuff injuries. This is a good lead in here, okay? When it comes to rotator cuff injuries, like I said before, we understand now that we have 4 groups that we're mainly concerned with: supraspinatus, infraspinatus, teres, correct? And when subscapularis, correct? We don't really talk about the subscapularis, and we don't really talk about the teres minor, right? It's very difficult to get an isolated teres minor tear. It just is, okay? But when it comes to supraspinatus tears, you're going to see this in your career a lot, okay? So rotator cuff, there it is. Most important, at least for the purpose of this lecture and for your studies in IPAP for now, is the supraspinatus. So you should understand that and where it lives and where what can happen when different pathology affects the supraspinatus. Okay. What you want to know, what you want to keep in consideration is acute trauma. Again, speaking more usually to younger populations. Degeneration is speaking more to seasoned populations, right? So older, okay. Chronic mechanical impingement, right? So they've had this history of impingement syndrome and this history of multiple x-rays showing this downsloping acromion, correct? Okay, so, and then decreased blood supply, well, that can happen anytime there's any kind of disease process. If there's decreased blood supply, so vascular or neurologic supply, right? Nerves, then you can have breakdown of the tendons, the muscle belly, and therefore the tendons, right? But what does it say at the bottom there? Full thickness tears are uncommon in less than 40 years old. How many of you guys thought that 40 was young? Come on, don't hurt my feelings.
Yes.
Okay. Okay, no, I'm just kidding. I'm sort of kidding. So your book says 40, right? We tend to use, in my training, in my experience, we tend to use 35. But what I mean by that is, in patients less than 40 years old, right, very commonly, you won't have the big tears, okay? Now, is that true? And I always get corrected on this, but sir, I was with somebody in my unit, and he had a big one. Yes, but that was in trauma, correct? That is addressed here, okay? Acute trauma. We're talking about what? Full thickness tears that are as a result of something that didn't occur due to major trauma, essentially. Make sense? Okay? 40 years old is still considered technically young. Okay? So there's always that saying that CrossFit wasn't invented by orthopedists, right? Because anybody over the age of 35 shouldn't be doing CrossFit. We love that patient population. That 35, 40-year-old population, they're our favorite. Right? Because they all think they're young, but their body knows they're old, okay? And that's just me telling you what the science of it is. As we round 35, get up in the 40s, again, our flexibility decreases, right? Our ability to recover decreases. If you don't believe me, you're either not there yet or you're lying to yourself, okay? But that's usually when we talk about that kind of that threshold. It's about 35 to 40. So for the purposes of your book, we'll stick with 40. Okay, guys? Are we good with that? Does anybody still not believe me? Okay, don't get it wrong on the test. Scratch that from the record, sir. So this picture here, that's very helpful, right? The red explosion right about there. Not helpful, but that's how your patient's going to describe his pain. If you guys have been to the doctor before, you know when you go to see a doctor, there's a picture that they put on there, you're supposed to draw your pain. This is what you'll see. How helpful is that? Not helpful at all, right? But what's more important to ask them? It tells you right there. What were you doing when this pain started? What makes it worse? What makes it better? You're going to get a lot of information just from asking those questions, right? So if they have difficulty sleeping on that affected side, that's going to tell you something. But here we go. Remember when I told you guys snack, crackle, pop? Okay.
Rice Krispies.
I don't know what you said. Rice Krispies, thank you. Now you're making me hungry again. So snack, crackle, pop. So you're going to ask the patient, do you have any popping sensation, any grinding sensation, any clicking sensation, right? And with what activities? And then this is where we first introduce, at least in my lecture, my topic, weakness. Do you have weakness? And what is the patient always going to tell you? Because it hurts. They're always going to say yes, right? For the most part, right? Patients are liars, okay? Because weakness, I already explained to you, is something you're going to decide whether they really have weakness due to concern for rotator cuff injury. Because, for example, with a supraspinatus, you're going to do what test? Job test. So if you have to discern in a medical way, you'll say the patient reports weakness, but he has a negative Job's test. You see how you kept it real, you kept it scientific, but you just called the patient a liar. Okay, but more importantly, you've decided that this patient may have a small tear or a partial tear, but they don't have what kind of tear? Full thickness tear, because is that when you're going to have true weakness with a Job's test? Okay, all right. And you guys know what the drop arm test is too, right? Which we'll discuss in the lab as well. Okay? We know what the drop arm test is, right? Okay, so that's how you're going to find these things. You're going to become detective and sniff these things out, okay? And then, again, it says overhead range of motion there, okay? Let's take a 10-minute break. We'll come back.
I know it was her. So they don't.
I don't know if you've seen it, I'm doing this a lot.
Drops milk. Oh my God. What is you right there?
I still don't know what
As soon as you should be here before the class ends. Yeah.
Oh, that's hard. Just looking at Travis's right now. 37 minutes. It'll go by another 2 Everything is on the. It's the little bit about everything. Living the dream. Like 4 positive a day. That's working.
Yeah, I'm happy to have this discussion, as long as you understand. We'll go through these, but anyways, short answer is yeah. So we have like if they do all this
It's gonna turn that front face about right here.
Yeah. Okay. So we were smiling there. Go. Straight face here. Face here. Happy, numb, sad, crying.
All right, you guys ready? Always ready? We're missing a few people. Yeah, too much popcorn. All right. I'm gonna slow roll it, but we're gonna get moving. Okay. You guys have an early day tomorrow. You're welcome. I'm gonna go at 10:00. Okay. So if we go a little bit longer today, I know a point I have to get to, just so we don't get too far behind. But we'll see where we're at. I have one person. I pick one person in every cohort. And I look at them, and when that person's meter's out, I know we're good. We gotta stop. Okay. I won't tell you who that is till the end, but I got my person. Okay. So
Everyone just falls. Everyone just falls.
I only pick one person.
Everyone go. Everyone's head down.
Yeah, I only pick one person. So I shouldn't have told you. All right. So what's that test in the background there? The drop arm test. Okay. So did I add this slide? Yes. Because I'm like, oh, what? We don't talk about drop arm? Like, but you guys know this, right? So what is this hike of the shoulder? What in the world are they referring to there? Is that high riding humerus? It can be. But more importantly, what it is, it's splinting. Okay? If it hurts somebody, do they kind of walk around like this? Right? Like the hunchback of Notre Dame or whatever you want to call it, right?
Nope.
They kind of keep their arm close to the body like this, right? And then when they go to lift their arms, they do this, right? That's kind of what they're more so describing. Really not the high riding humerus, right? So take that for what you will, okay? I've had students stop me and say, what the heck is that? I'm like, I think they're describing this, okay? So moving on. All right, but that is the high riding humerus, correct? You guys have seen this now, how many times? A couple of times with me, right? So do you think that's pertinent, something good to know? Something you should be able to wake up from a dead sleep and be like, that's a hydrating humerus. Yes, so understand that, okay? And it's literally just that relationship between, the head of the humerus and the glenoid fossa, right? That's what we're talking about. So again, you're gonna get the same imaging, nothing changes. AP and hopefully an axillary as well, okay? Scapular wide view if you can. All right, there's a bunch of other views you guys will learn in phase 2 that I won't get into just yet, okay? Can you see acomoal variations or spurring? Yes. And sometimes if you change the angle of that beam, can you see that more as a profile of it? Everybody understands what I mean by profile? You change it so you're looking at the surface a little bit better. So that's what they're getting at there. They're saying that there's special views that you might get, right, that we don't necessarily test you on, I won't test you on, that changes the direction that beam is going in and tries to get the contour of that bony surface, whatever that is, a better view of it so you can decide if that is the area of concern. That's all that's saying. I will not test you on that. Okay, but those of you who know what a valve view is, what valve view is, those of you who know what a West Point view is, good for you. Okay? So MRI, everybody sees the rotator cuff tear, right? And the supraspinatus tear, you all see it. 100%, 1000%. I could give you this picture not labeled and you'd see it, right?
Oh, yeah.
No? But you'll spend some time looking at it. All right? Because you would agree that all this body here, right, should come and insert here, right? The answer is yes, because it's labeled, right? So, but all this here should come all the way over and insert here. So is that a high grade rotator cuff tear then, if it doesn't insert where it's supposed to insert into?
Yeah.
Yeah, so that's a full thickness tear. So we just got there. Now we understand that, okay? That's why we get the MRI. If you do a physical exam, positive drop arm, positive Jobs, they're reporting weakness, right? And you're concerned about it, you get the MRI, this is what you see. And then can you also tell, because remember it's supposed to attach here, right? Right where that white line is, okay? Right where that white line is there, that's where it's supposed to attach. But then, especially if it's a chronic tear, right? Could you then have to look at it and see how far back it's retracted, right? Well, you guys know what I mean by retracted, right? It's under tension. So if it's not inserted anymore, it's going to pull back, right? And it's going to pull back pretty significantly, right? So yes, the answer is you will see the amount of retraction. So then you have to gauge what kind of surgery needs to be done. And we already talked a little bit before about augmenting with tissue, right? So we have to decide what kind of, if we do have to augment with tissue versus augment it with different instrumentation, okay? And I'll leave it at that, okay? But that's the reason we get MRIs. Are we good with that? Okay. So adverse outcomes disease, obviously if they can't lift their arm above or maintain their arm above horizon, they can't lift their arm above their head, they will continue to be unable to, okay? Chronic pain, sure. Weakness, that's the whole point, okay? So if you have a rotator cuff muscle that's out, do you think the biomechanics of your motion is going to be altered? Yes, right? Everybody knows what a mortar and pestle is, right? Right? The pharmacist taught you that, right? So you guys understand that a mortar and pestle, right, is that compounding, right? So you can think of one side of it being the humeral head, and the other side of it being the glenoid fossa. So if one of the rotator cuffs is out, the other ones are still intact, correct? So the way that grind is occurring is going to be altered, and that can lead to advanced degenerative changes, otherwise known as osteoarthritis, specifically glenohumeral, right? Okay, we all got there. Okay, good to go. So non-operative treatment, okay, we know that. That's the same old ortho thing, right? So injections, do they play a role with rotator cuff injuries?
Yeah.
They can, especially if they're low grade, right? Meaning minimal, right? You get the MRI, you can see it's minimal, right? There's really not much to chase there, no big surgery, okay? You might try an injection, get the inflammation to calm down. With low grade partial tears, right? Meaning not significant, that's what I mean by low grade. okay? Can they sometimes scar in and the patient does just fine without surgery? Yes. How are you gonna decide that, right? That's why it says judiciously, right? So that's gonna be something, either you're skilled at it or you refer it to us and we're trying to decide whether or not we feel that the risk versus the benefits of an steroid injection, which side we're on, okay? All right, because can it weaken the tendon? We already know it can, okay? So don't let that statement fool you. Don't forget the word judicious, okay? Be careful with that, okay? I will tell you, when you first start practice, if you're thinking about doing it, you know they have a supraspinatus insertional tear, because that's what it is, right? It's supposed to insert there, it doesn't, whether it's partial or full, that's an insertional tear, okay? That's all I'm saying, okay? And you're trying to decide, should I do an injection, or are you going to refer it? Yes, yeah, please do, okay? Because eventually I can talk him into surgery. All right, so this throws people off, but young, acute traumatic tears within 6 weeks, okay? Again, does that just say young tears? No, young people with tears? No, it says traumatic, right? So that's why the history leads you in that direction, okay? So when you're reading vignettes, either in my test or in PANTS, you're looking for clues. You're looking for indicators of the timing, the chronology of whether it's chronic or acute, basically is what I'm saying, okay? If it's an acute tear in a young person, how many weeks do we have to do surgery on it? Right? Because does that retraction kind of take off? And do they start scarring in and healing it in a position that's not optimal? That's all that's saying. Don't let that throw you off, okay? And I'll address that again in test for you if you need me to, okay? So the next group is just all comers. You have rotator cuff tears of varying degrees, varying chronicity. You've been holding on to it. You've been sending them to physical therapy. You did everything we're supposed to do. You sent them and you told them, Bishop, to make sure that they do, right? What? Rotator cuff strengthening and scapular stabilization? That's what you told them, right? You wrote it in the note. You made sure that they did it. And now they come back to you at 3 months and a day, right? And you're still don't know what to do with them. Where do you send them? Me, someone like me, I'll be retired, right? But, and then what do? Right? We offer them a rotator cuff repair. We offer them a number of things. Don't get dialed into that, okay? The point is, this is your decision point for referrals, okay? Because as primary care managers, are you guys going to be the knowledgeable in a lot of things, but masters of none?
Jack of all trades.
Jack of all trades, master of none, right? Thank you. You said it better, sir. Thank you. So, yes, and this is an example of that. You get to a point where you're like, I don't know what to do. You know what to do. You send them to the next level of care, okay? All right, rotator cuff repair. Everybody understands all this right here, right? I'm going to ask you 15 questions on these techniques, right? These suture rows, whether it's a double bundle, single bundle, whether that's an anchor, you know, what the material of that anchor is. No, I'm not going to ask you any of that. That's just in there to get you to understand that we can do it arthroscopically. But guess what? If it's a major rotator cuff tear, meaning involving more than one rotator cuff muscle group or more than one tendon, right? Do we have to do a big open procedure? Potentially, yes. Okay? So just understand there's a spectrum there. Does that make sense? That's why your physical exam, again, is super important. Okay? Because even though we focus on supraspinatus tears, can you have supraspinatus tears and subscap tears that occur in the same patient? Especially if they're seasoned, like me? Yes. Okay? Right. So that's when we see those. Okay? More seasoned patient populations. Okay. All right. Anybody confused by this? I just hopefully summed it up. 6 weeks non-operative treatment. That's partial thickness tears. That's not full thickness. That's all that's saying. Okay? If it's not full, what's the opposite of full for the purpose of this course? Partial. Don't get caught up in the minutia. I'm not asking you to grade it here. This is different. Okay? Very commonly when it comes to rotator cuff tears, tendon tears, when it comes to rotator cuff specifically, we use the words high grade and low grade in our specialty. And that basically just denotes whether it's full, partial thickness or full thickness. Okay, so we don't necessarily grade them. It's more of a percentage thing. And how do you decide what percent is torn and where it's torn from? All right, perfect. You guys get it. Just don't get it wrong in the test, please. Okay. All right. Conclusion: AC injuries, common joint injuries. Now, I told you guys about that chart, right? I told you guys that you can have instability both superior, inferior, but you also want to check for instability from anterior to posterior, right? What's that one test that we do to check for anterior posterior instability? The shear test, right? Good. So we're all on the same page. Okay, so don't let that throw you off. Okay? That's all that's saying. Okay? When it comes to AC joint injuries, 1 and 2 is you.
Clinic
1 and 2 is you. Okay? You can hold on to those with a relative sense of like, I think we're okay here, sending physical therapy, NSAIDs, activity modification. 3 is kind of a turning point, right? What are the important things to ask somebody? What do you do for a living? Are you right-handed or left-handed? Right? More importantly, are you stationed here or are you only here like a week? All right, don't send me somebody, don't put a referral in and I get all excited. And then I'm like, where is this dude? Captain Carbiner, where is he? And he said, oh, I didn't know, but he left last week. Then I get all sad, okay? But well, when it comes to AC joint injuries, you'll never do that, I know. But when it comes to AC joint injuries, that chart, I don't want you guys to be nervous about it, okay? 1 and 2 is you. 3 is a decision point. 4 or more is ortho. Doesn't really rhyme, but I'll make it work, right? But that's kind of your decision point. Brachial plexus injuries, you're just going to have to spend time on it because we're also going to start talking about thoracic outlet syndrome. And you'll be like, oh my goodness, I don't know where I'm at anymore, right? But I went slow yesterday for a reason. We're going to start picking up pace, okay? But I'm just telling you, you got to lay it out, understand how they're different, right? How that's different than cervical radiculopathy, how that's different from thoracic outlet syndrome when we get there. Did I give you a resource for that? There's a little link at the bottom, right? I give you a little resource in case you want to dig a little deeper. Should you read your textbook? I know some of you are. I know some of you aren't, okay? But at the same time, that can help you, okay? But you got to get to a point where you understand the difference. Because when you're given a vignette, you got to be able to pull out those little nuggets I keep dropping, okay? Make sense? Frozen shoulder, is that the same thing as impingement syndrome? No, don't get those two confused. And when it comes to frozen shoulder, how long does it take for somebody to get better? 6 months to 2 years, right? And so are you going to send them to us if they're improving? You're going to send them to us if they are not improving, correct? No signs of improvement. And what's the adjunct we do, not necessarily right away, but that we might do if they're not showing improvement, but we think that this might get them over the hump? Corticosteroid injection, okay, right? So incidentally, the adhesions are in the capsule, correct? So where does the injection go? In the glenohumeral joint. So is the risk of infection 0? No, that could be a really bad day if they get infected from that and it was a completely unnecessary and not indicated injection. Make sense? So be judicious, okay? Impingement syndrome, I think we'll just beat that to death. Rotator cuff injuries. Rotator cuff injuries keep coming back because people can't really discern what I'm talking about when I give like clinical scenarios. Don't worry, I'll give you guys practice questions. You'll ask me questions. We'll figure things out. Okay? But when it comes to rotator cuff injuries, again, all things supraspinatus. Okay? You must understand that completely. You must be able to pick out the pathology and understand why those physical exam findings may be the way they are. Because will that guide your referral decisions? Yes, right? So if you make the wrong choice in a referral decision, might you get that question wrong on pants? Yes. So I don't want you to get that wrong on pants. Okay? Good to go? Questions? Question mark? Okay. All right, we're going to get into biceps tendon ruptures, and then I've already checked on my meter, and he's already running out. Okay? So we'll get through some bicep stuff, maybe one more topic, and then we'll get out. Okay? But when I went through the anatomy and physiology review, people were like, I don't know origins, I don't know insertions. Okay, fine. I understand that, you may not have hit it in a while, right? So I will go through this a little bit just to make sure we're on the same page before we get too far into it. Okay? So I can't just add things to the lectures unless I go through a committee. But here's a picture that I would just add as a supplemental slide. Okay, good to go? So understanding that the biceps brachii, there's two eyes, there's two muscle bellies, okay? Right? So the biceps brachii, the long head of the biceps here, right? It goes up, over, and inserts into into the glenoid fossa, the supraglenoid tubercle, okay? That's the long head of the biceps, okay? The short head of the biceps, what is this structure right here? It's labeled, so yes, you are correct, okay? That's the coracoid, so important to understand those two things, okay? But when we're talking about biceps ruptures, right, we're talking about the long head of the biceps, okay? That's kind of what we're talking about, okay? Does any questions about that? And what is this, what is this structure here where the conjoined tendon inserts into distally at the proximal radius? Radial tuberosity, okay? So when we talk about getting x-rays, someone might say, well, Major Davalos, if this is a soft tissue injury, right, why would we get x-rays? Well, is that insertion really strong? Strong, right? Really strong insertion, one of the strongest ones you got in your body. Not the strongest, that's the Achilles insertion, right? But so do you think if it pulls off the bone, if it pulls hard enough, excuse me, I just gave it away. If it pulls hard enough, it'll take a piece of bone with it? Yes. So if there's a question about the diagnosis, that's why the imaging can help you. Good to go? Okay. All right. We go with that? Another quick little review. Yeah, I thought that was helpful. Hopefully you do as well. If not, continue to study farm. Okay. Oh, whatever. Just pick a topic. All right, so that's what we're talking about. So when we talk about biceps tendon ruptures, are we talking about partial tears? No, so that's a full thickness tear. Okay, don't get this terminology confused, okay? And we're talking about proximal biceps. Do you think we're talking about the long head of the biceps as it inserts on the glenoid fossa at the 12 o'clock position? Yes, because that's what it tells you right there. Supraglenoid tubercle, 12 o'clock. I added this picture. Do not tell anybody. I will deny it, okay, even though it's recorded, right? So this is how I found out I wasn't supposed to do this, right? But hopefully it helps. So you see BT, what do you think that stands for? Okay, biceps tendon, right? We're on the same page. So BT, biceps tendon, is that the 12 o'clock position? If you were looking at the glenoid fossa, right, as a clock face, that's the 12 o'clock position. Okay? Now, is that also continuous with this kind of light blue, white ring here? Yes, it's continuous with that, right? Contiguous, I should say. Right? So is that the labrum? Yes. So the reason I need you guys to understand this is because when you're talking about biceps tendonitis, you're not talking about proximal bicep tendon ruptures. That's a completely different diagnosis. Right? A rupture means it's out. So in orthopedics, we very commonly use the words in or out. So if you call me on the phone and tell me somebody has a tendon rupture of any body part, I'm going to tell you, say, well, what's in and what's out? So what am I asking you? What's your physical exam? When you're testing these different parts of the body with these special tests, or with these tests that I teach you, hopefully, you learn, right? That's what I'm asking you, okay? So understand that we are talking about proximal, distal we'll talk about later, okay? So most of these things occur in older patient populations. That's what the literature says, okay? Again, someone in here might be like, well, I know somebody who had a proximal bicep tendon rupture, okay? The military population tends to be just a little bit different, and I say that in a kind and loving way, okay? But according to the literature, it's uncommon in young adults, with the exception of weightlifters and throwing sports. Okay, so do you think on pants, it might be a really good question to throw in there that the patient is a younger patient that is a weightlifter who maybe went too heavy? Yeah? Yeah, maybe that's a good scenario, right? Okay, does anybody know what the iron cross challenge is? Don't demonstrate it, okay? right? But that's where you stand like this, right? Your arms to your side, and you hold 100-pound dumbbells, right? And you just hold them there until something pops, right? Right? So sometimes you see that, okay? All right. All right. All right. So don't tell anybody about that picture, okay? So when we're talking about bicep, proximal bicep tendon ruptures, when the person says that they felt that snap, where are they going to say they felt it? Proximal shoulder, so closer to the shoulder, not closer to the elbow. That makes sense, right? Okay? So where is that audible snap? Excuse me, let me go back. So it is an audible snap. Has anybody ever heard an Achilles tendon rupture or anything like that? Somebody said they did, right? You heard it. It's like, I've never heard it, right? But apparently it's pretty profound, right? So they may say that to you. And then when you look for that bulge, let's think about this real quick. I already told you, when the tension is still maintained because things are intact, right? They're going to pull still, right, in that direction. So if proximally that attachment at the 12 o'clock position at the supraglenoid tubercle is not intact, what's going to continue to pull? The distal insertion, which is at the radial tuberosity, correct? So that's going to continue to pull, right? So where is the bulge going to go then? Right? So this is what it's showing you here. It's no more attachment there, right? So the bulge is going to be distal, correct? Because that's where the tension is still maintained. Okay, so that's what's called a Popeye deformity. Okay, Popeye deformity. Everybody knows who Popeye is, correct? Is Papayero? Okay. All right, good. So this is not helpful unless it's acute. Okay, this actually looks more chronic to me, to be quite honest with you. This looks like it's been popped for a while. Okay, but initially you might see that swelling more proximal. Okay, all right. Do you think does everybody see the bulge here? How it's more towards the elbow, and there's a big area here where there doesn't seem to be any muscle belly, right? So if you put your fingers in that area and push down hard, you don't want to have to push too hard, right? Will you feel a gap there where the muscle belly should be? Yes, that's what they mean by palpable gap. Okay, so if you call me on the phone and tell me you think you've got a proximal bicep tendon rupture, I might ask you, okay, does the patient have a palpable gap? And that's what I'm asking you, okay? The bulge is in the lower arm, though, bless you, because it's retracting distally. Somebody said thank you. So, and then where are they going to have, where did it pop from? Does the biceps tendon run through the bicipital groove? Yes. So might they have pain at the bicipital groove? So this is all putting it together, right? Now again, not just the sparkle fingers or magic fingers, as Colonel Sylvester calls it. You're actually taking that information and putting it together. Okay, and when you have them resist, right, just literally resist bicep flexion, will it hurt? Absolutely. Okay. Will I make a patient do that? Probably not. But when they do this, the bulge is going to go even more distal, correct? Well, you understand that concept, right? So then a distal biceps tendon rupture, when we get to it, you understand it's the opposite, right? But we'll get there, okay? All right, so everybody sees this ecchymosis, I know this. Why does it was probably only here, right? That's where it started. It was probably only here for this side, right? And then it took off and now it's down here. Why is that? Gravity, right? We can't fight gravity. 9.8 meters per second squared, still present, doesn't matter, doesn't care, okay? But initially, if you document that they had ecchymosis and a palpable gap and tenderness of the bicipital groove, then that tends to get you to a pretty solid understanding of diagnosis, okay? Good to go? All right. All right, so again, why don't you get x-rays? Sure, rule out other fractures, but you won't necessarily see anything. Is it soft tissue? Yeah, soft tissue. But you'll still get them, right? Because you still want to rule out other trauma, other pathology. Okay? MRIs. This is the one time, besides radiculopathy and cardiac quietness, stuff like that, I will urge you to get an MRI soonest. Okay? Because like I said, once that thing pops and things start pulling in other directions, do things want to kind of heal and scar down in other directions? Yes, right? Especially those bodybuilders. You know, they come in and say, oh, it just doesn't look right, doc. right? You gotta get to it pretty quick, otherwise it might not look right for a long time, right? So again, you gotta figure out how far it's retracted, what's involved, right? What kind of surgery you think you might need, and get to it soonest, so an MRI as soon as possible, right? So sometimes the people that have these injuries, according to the textbook, because remember, we're talking about young patients or old patients? Older patients, right? They have concomitant or also have rotator cuff tears present, okay? And that's just kind of an aside note, right? So maybe we'll get the MRI just to make sure that not only when we go in there and fix the proximal biceps tendon rupture, we also have to address some rotator cuff pathology as well. Do it all at the same time, right? That's the best way, right? Okay. Okay. You see that bulge? You see the arrow? Don't tell anybody I added the arrow, okay? It wasn't me, okay? But then when they do the resisted, that's the direction that the muscle belly goes in, okay? Right? Cosmetic deformity? Sure. These are the numbers you need to know. When it comes to proximal, 10% elbow flexion and forearm supination strength. 10% flexion and forearm supination. Is that what the biceps does? Okay. Is 10% significant? No, not really. Most patients will be okay with it. Okay? Okay? And this point will become valid later on when we get to distal bicep. Because I will tell you that most patients with this, because remember, these are older patients, right? Are they swimsuit models? I'm not. Maybe I am. I don't know. But I'm just saying, like, if it's just a deformity, am I going to go through surgery for this? No. The answer is no. If I get this at my age, that's it. It's just going to look like this. I'm cool with it, right? But I'm just telling you, when we counsel our patients on it, we tell them this information. 10% what? Elbow flexion and forearm supination. So then the decision point is left up to the patient. Okay? Does that make sense? Because when I get to distal bicep tendon ruptures, do you think those numbers are going to be more significant? And I try to talk every single freaking patient as they get in surgery? Yes. Right? So I'm giving it to you now. Focus on these numbers, okay? Because you'll understand why the decision points are different, okay? So again, operative, why would we do surgery for it? Because they're young, right? They did something stupid potentially, right? But they still have to go the rest of their lives, right? They still have to be able to do certain activities. And that maybe that 10% will make a bigger difference to them, okay? Less than 40 years old, there's the 40 again, right? Right? You guys already know the non-operative stuff, right? I don't need to go through that, correct? We're going to skip a few steps here. But when we talk about the surgery for it, biceps tenodesis, we're going to take that tendon, right? Does the tendon insert inside the shoulder joint? It does, right? It inserts at the 12 o'clock position at the supraglenoid tubercle. Okay, we're going to take that tendon, right? We're going to find it arthroscopically. We're going to go in there, we're going to fish it, right? And then we're going to make another incision, and we're going to insert it outside of the shoulder joint, right? And set tension on it, right? So do you think we might have to cut some of that tendon away? Yes, we will have to set that tension. So that's what's showing you there. See where that anchor is? Isn't this tendon supposed to come up over and right about here? Yes. So it's supposed to come up over and right about here? Yes. So we're going to reset the tension on it by shortening a little bit and insert it somewhere else, more distal to the shoulder joint. Okay? That's all you need to know. That's what a biceps tenodesis is. Okay? Good to go? So do you think they're still going to have that Popeye deformity? We set the tension on it, right? So the muscle belly should be pulled more proximally, right? Could they still have some? Yes, you are correct. You're not wrong. They could still, but it won't look like it did in this picture, right? So they can go back to their modeling career. Okay? All right. Okay, good to go. So functional improvement is often modest, because I said it was only 10%, right? So that's where we come up with that. Stiffness is always possible, especially if they don't maintain compliance with their post-op rehab, right? And then surgical scar with little cosmetic improvement, in parentheses, bodybuilders. That's a real thing, by the way. Every Marine Corps staff sergeant or above is a professional bodybuilder. Okay? So I've heard all the stories. Doc, I've got to get it fixed. Sure you do, staff sergeant. Absolutely 100%. So, okay? So what are you never going to forget? You're never going to forget that if somebody has a concomitant rotator cuff tear, that then it makes it even more compelling, to send those patients, right? That's almost becomes a red flag. Although I don't like the term red flag here because it denotes like death, right? If nothing's done. Nobody ever died from proximal biceps tendon rupture. But it just elevates your level of decision making, correct? All right, okay, good. All right, I don't want to go into this. This is a good topic. We will cut today, okay? We'll start at 10:00 tomorrow. Have a good afternoon.